large left vein. We go down a little bit further. We see, actually we're going up a little bit further to see the left pulmonary artery, large left vein, which makes a vascular shadow within the curve of the artery, as we saw on one of the earlier diagrams. We even have a kink in the right pulmonary artery here to make it look confusing. We look at the lung window. Notice that the bronchus may be curved, may be bent by this accumulation of vascularity. Not all deformities of the bronchus represent pathologic masses in the mediastinum. Large vessels can do it. And as we go up a little bit further, getting close to the aortic arch, here the calcification along the bottom of the aorta, the AP window. Notice how peculiar this shadow is as the pulmonary artery goes higher along the aorta than it would normally because it's so distended by heart failure. This is a very confusing appearance related, of course, to partial volume effect, and you mustn't confuse that with a mediastinal mass. Notice the portions of the azygous vein that we see as it makes a generous arch and is a generous size in the mediastinum. This is the highest cut in this patient that I'm going to show you. We should be seeing the 3 arteries and the 2 veins. Well, everything is very big and irregular. Subclavian artery looks huge. I can't really identify the common carotid very clearly. This is the brachiocephalic artery, and this is the right brachiocephalic vein. Left brachiocephalic vein is coming across here, but we really seem to have an awful lot of vascularity in this region. And I think that you can often be very confused by this, particularly in a non-contrast study, but I assure you that everything you see here represents distended blood vessels in a patient with heart failure. Let's turn back to the right side of the mediastinum for a moment. Take another peek at the azygous vein and the azygoesophageal recess. Here on this diagram, the azygous vein is laid out for us very beautifully. Here's the superior vena cava, and coming into its dorsal aspect, the azygous vein. The azygous, of course, has come up from below, though sometimes we speak of it as going down or going posteriorly, but in fact it's coming anteriorly from its proper course. And notice that there may be tributaries from this side of the spine, just as there are with the hemiazygous, running into it just at the beginning of the arch. That means that occasionally, as you make cuts above the level of the azygous vein, you'll see a good-sized vein posteriorly, where normally you only see a good-sized vein inferiorly to the arch. As we've seen on normal chest films, the pleura and the right lung come up against the trachea and the esophagus, and here below the arch we see the esophagus with a phrenic nerve overlying it. In this region where the lung indents, of course, is the azygoesophageal recess. If you look very carefully, you can appreciate that right in front of that is the right bronchus. Here the right upper lobe and the bronchus intermedius, and it's this thin wall of the bronchus intermedius with aerated lung behind it in the azygoesophageal recess that gives us a line on the lateral chest film and also gives us a thin posterior wall to this structure on the CT scan. Here is an example of the arch of the azygous vein seen almost in its entirety. Notice that it doesn't just go from front to back, that it curves around medially, and you can see that sometimes on plain chest films as well. Notice that from the configuration of the bronchi, they were already just about at the level of the carina. What's the structure over here? Well, it's not the azygous vein yet. We have another mass there. Oh yes, we've got an esophagus to consider. All right, that's the esophagus. And of course we have the left pulmonary artery coming out of the main pulmonary artery, and you can see the ascending and descending aorta on this scan as well. If we go a little bit higher here, above the AP window, we see the calcifications, the esophagus, and over here we see a tributary a superior intercostal vein on the right side above the level of the aortic arch. Notice also the fat pad, very generous in this patient, between the superior vena cava and the trachea. Now, here's a patient whose plain film of the chest suggests a mediastinal abnormality on the right side. If we look at the shadow of the tracheal air column and the contour where it goes into the right upper lobe bronchus, instead of having a parallel line for the superior vena cava, we have some kind of convexity over here. Now, the azygos vein may be large and convex, but this is much too irregular and too far lateral for that structure. So let's look at what we have on a CT scan. We start near the level of the aortic arch, ascending and descending with a little bit of calcium in the bottom of the arch. The superior vena cava, notice the contrast material in the superior vena cava is a little bit eccentric because of the flow, presumably from the left brachiocephalic vein, not having mixed completely with that from the right, so that the contrast is not uniformly distributed. Now recall there's supposed to be a fat pad between that vein and the trachea, but in this patient there's a soft tissue mass. And this soft tissue mass extends sufficiently far laterally either to be border forming or to push the superior vena cava locally into becoming convex. This, of course, is an abnormal shadow, and if we go a little bit higher up, we still see that there is a mass shadow over here in the fat pad between the right brachiocephalic vein and the trachea. What is this? Well, it's a large lymph node, and in this case it happens to be due to tuberculosis, which is not an unknown disease in this area. If we take the anatomist's version of what we're looking at, here the aortic arch, here's this cluster of lymph nodes, which the anatomist has drawn of a pathologic size. They may be either above or below, or in this case, adjacent to the arch of the azygos vein. That's the region that we're looking at. Those are called the paratracheal nodes, even though you can see that they're really anterolateral to the trachea. These nodes may be appreciated on plain chest films very nicely when they're calcified. If you look closely, you'll see a series of calcified lymph nodes all along here. You can see that the shadow of the superior vena cava, this smooth line out here, is well preserved. These nodes, though enlarged, are not big enough to displace or deform the border of the mediastinum that the X-ray is tangential to. If we look at this in the lateral view, we can again see the relationship to the air column of the trachea. They are anterior to it, and they are deep to the superior vena cava, which of course is not visible on the lateral chest film. Remember, superior vena cava goes in front of the right pulmonary artery, whose shadow we see here. Those are the paratracheal nodes. They're usually easy to detect when they're significantly enlarged, but here's a patient who has a cancer, which is just off the field here, who has metastases in the upper part of the hilum, who has a normal paratracheal stripe, a pretty normal-looking superior vena cava shadow. This region, I think, would be easily passed as being entirely normal. But in fact, it isn't normal because there is a lymph node mass displacing the azygos vein laterally and filling in the fat pad, a large metastatic lymph node from lung cancer. This is a very common region for these to occur. This is the lung window on this same patient, showing you where the lesion is. I wanted to point out how much better these windows are for demonstrating the contours of the bronchi, for appreciating that there's more tissue surrounding these bronchi than there should be because of the lymph node enlargements. Particularly, notice the thickening of the wall of the bronchus back here. Now, this is the right main stem bronchus, and this is the takeoff of the upper lobe, and we're going into the bronchus intermedius, and there should be aerated lung behind this bronchus. Instead, there is a soft tissue mass, which represents the lymph node. Notice how much more difficult that is to appreciate on a mediastinal window scan of the same region. There's a line here, but it's not remarkably thick, and you might have trouble recognizing that as significant lymph node enlargement in relation to this cavitating carcinoma. Let's move on to one more region. This is an important region in the study of the chest X-ray, and it's turned out to be a very important region in the analysis of the CT scan. Now, it's a very difficult region in the chest X-ray. I'm talking about the subcarinal region. It's very difficult because the film is often not sufficiently penetrated to show it. You must have visualization of both main bronchi quite clearly. You must see air in the lung in the azygoesophageal recess, and then you have at least a fighting chance of seeing a mass lesion in the subcarinal region. However, very often this is not the case with average chest films. CT scans turn out to be very useful, though often a little bit difficult to interpret in this region as well, and we'll see why in a moment. Now let's look at the anatomy diagram first. The artist, once again, in portraying the lymph nodes in this region, has showed us nodes which are clearly pathologic in size. The aerated lung should come in well underneath the carina with very, very little tissue between the bronchi once you get past the carina itself. A very thin layer of tissue should be present there. Notice the proximity of the subcarinal region to the esophagus. And indeed, the esophagram is a useful tool in appreciating large masses in the subcarinal region. What should be normal there? As I pointed out before, you may see no significant tissue, or you may see a very thin density with fat in front of it and air behind it. That's a normal appearance for the subcarinal region. Many scans, particularly when they're dark, you don't see any tissue density in here. You just see the fat and the lucencies of the two bronchi. That, again, is a normal appearance. If you look at this region with the help of the lung window or an intermediate window, these windows which show you the vessels very faintly but show you the intraparenchymal structures, I think are very useful for this kind of analysis. Here we are again at the level of the takeoff of the upper lobe bronchus, the thin posterior wall with air going into the azygoesophageal recess. A little bit of tissue between the two bronchi, just at the level of the carina, with fat, this darker gray, in front, and a little bit of fat behind next to the denser shadow of the esophagus. If we proceed caudally a little bit further, again we have the air in the azygoesophageal recess. The two bronchi are separated even further. This is now the bronchus intermedius itself with its thin posterior wall. You notice this is almost all fat density filling in here, no soft tissue density. And you see in front of it the right pulmonary artery. The right pulmonary artery crosses the mediastinum below the carina. Well, here's a chest film. Can you see on this chest film the aerated lung coming over to the esophagus in this inferior portion of the azygoesophageal recess, but instead of continuing all the way up to this level, that line is displaced outwards and around this mass shadow, a huge subcarinal mass. Notice that it is not border forming with respect to the mediastinum, except on a well-penetrated film where one can appreciate a little bit of this outline. That is a very large mass. The lateral film from the esophagram makes that quite clear. Instead of flowing smoothly downwards, the esophagus is displaced. Notice that displacement by a subcarinal mass is more cephalic than displacement by an enlarged left atrium, which would be at this level. Well, the CT scan is going to look pretty dramatic. This is an old CT scan on this case, and so it's not very good quality, but it shows obviously a huge mass encroaching on the azygoesophageal recess. The right bronchus intermedius is almost completely encircled by tumor. You didn't need a CT scan to analyze that case. This case, however, there is a carcinoma down here, but the mediastinum is really quite unremarkable. Even if this film were better quality, we still would not see any abnormality, and if we did an esophagram, we would not see any abnormality, and here's the reason why. As we look in the subcarinal region, we see the separation between the bronchi, And you notice there's a soft tissue mass here, displacing the fat anteriorly. We're back to fat again here. So this is an anterior subcarinal lymph node. Back here we have air in the esophagus, and this is certainly not going to be displaced by a lymph node up there, but that is a lymph node of pathologic size. If we go down a little bit further, we can see that was just the top of a very large node that really fills the subcarinal region. But once again, the esophagus is back here and is not likely to be displaced by even so large a node. Furthermore, the azygosophageal recess is not significantly encroached on or deformed by this very large metastatic lymph node. Therefore, one finds that one's sensitivity for abnormalities is greatly increased by looking at this region on the CT scan. Let me show you a couple more examples. Different patient, a very nicely demonstrated subcarinal lymph node, also metastatic. There's also some tumor encircling the bronchus intermedius here. Fat, again, of normal distribution back here, and then esophagus. This is only visible clearly on a CT scan. Another example, this one much more subtle. Here we're a little bit further down below the carina, and you can see the azygos vein here, the aorta, the esophagus, and an extra lump of tissue. We should see fat over to here. Instead, we see about a 1.5 centimeter to 2 centimeter lymph node. Now, that's clearly a pathologic lesion. Subtle, visible only on CT, but an important finding nonetheless. Well, we're back to the beginning again, and I wanted to reinforce the fact that we have looked only at what I think is the most clinically important portion of the mediastinum, really defined by these 6 cuts that we have used as representative diagrams. Findings further down in the esophagus, hiatus hernia, and so on are easy to work out, and we're not going to spend any time on those. Aneurysms of the aorta are another interesting subject, which we will not have time to deal with. In another talk, we will discuss the meaning of these other numbers, the lymph node regions, and their role in management of carcinoma of the lung. I think that CT has greatly enhanced our ability to analyze the mediastinum. The ability to distinguish vascular from non-vascular structures, whether contour forming on the chest film or not, has been extremely valuable. Now, for your purposes, I think it's very important that you spend time analyzing some thoracic CT scans with the accompanying chest films in hand until you're comfortable with these anatomic structures. I hope that this presentation has been a useful introduction and will be a useful refresher on this anatomy.